understanding measures, and data availability in the ACHN program. Attention, please mute your phone and computer microphone. Use the chat box function to type in questions. Questions answered at the end of the webinar. Good afternoon. I am Connie Fales with the Analytics Division, and I will be presenting on paying for quality, understanding measures, and data availability in the ACHN program. This is a reminder of the methodology of attribution that many have seen before. We will walk through the importance as it relates to quality measures. Attribution is the process that will be used to associate a Medicaid recipient to the PCP group that provides primary care to that recipient. PCP groups must sign the two agreements, one with Medicaid, one with the ACHN entity to participate. Under the ACHN program, Medicaid recipients will be attributed to PCP groups based on historical claims data utilization. PCPs are encouraged to continue seeing patients as medically necessary on a consistent basis to increase the likelihood of attribution. Attribution is a critical factor in determining distribution of bonus payments among eligible providers. Attribution will replace panel assignments. Under ACHN, the Patient First program ceases to exist and capitation payments will no longer be paid. A smaller number of attributed members compared to members in the previous panel does not necessarily equate to reduced payments. Some guiding principles of attribution methodology: consistency with ACHN's principles of for activity, continued emphasis on care coordination and health outcomes with a focus on preventative care, acknowledgement that some recipients require specialist care, evaluation of activities at the group level. Key steps in attribution. Medicaid recipients that have met criteria for the ACHN program for 3 out of the previous 24 months will be attributed. This does not have to be a continuous period. The previous 2-year period history of face-to-face provider visits, both preventive visits and regular office visits are scored. Preventive visits receive a higher point value. Recent visits are scored higher than older visits. PCP visits receive a higher point value than specialist visits. The previous 12-month history of filled prescriptions for chronic care conditions are scored. The attribution process. On a quarterly basis, the Medicaid Agency will determine attribution for each Medicaid recipient under the ACHN program in accordance to the following process. Point values for face-to-face visits will be assigned to the individual provider that performed the service. The individual PCP scores will be combined to form the PCP group's total point score for each patient. The PCP group with the highest number of points will have the Medicaid recipient attributed to that PCP group. If a specialist group has the highest number of points, then the specialist group will be attributed the Medicaid recipient. Guiding principles for quality metrics. The Department of Health and Human Services, HHS, identifies metrics that pertain to preventive services, treatment, and management of medical conditions. The Centers for Medicare and Medicaid Services, CMS, collects quality measure data from all 50 states in an effort to strengthen quality of care and health outcomes. Specifications for adult and child core set measures are released annually by Health and Human Services. All measures are nationally validated and have standard specifications. The ACHN benchmarks are based on quality performance scores as reported by the various states and were adjusted as necessary. The primary focus is measurable, attainable improvement in healthcare outcomes. Quality measure benchmarks. The benchmarks are performance rates for frequently reported measures among states. The benchmarks are from CMS and are determined based on data captured in all states that report the measure. The data. Quality measure rates are calculated using the administrative claims data providers submitted to the agency. Quality measures will also utilize data from other state agencies when applicable. Quality measures will be evaluated by a third-party external quality review organization. There are 8 provider quality measures, 4 child measures, and 4 adult measures. Listed are the measure acronyms and the names of the measures. Acronyms are how CMS records the quality measure. The child measures are well child visits in the 3rd, 4th, 5th, and 6th years of life. Adolescent well care visits, childhood immunization combination 3, immunizations for adolescents combination 2. 4 adult measures, antidepressant medication management in the continuation phase, comprehensive diabetes care, A1C testing, follow-up emergency department visits for alcohol and other drug abuse or dependence, and chlamydia screening in women ages 21 to 24. Quality scoring. Let's walk through an example with the Fletcher family practice. The practice met the benchmark target for 3 out of 5 quality metrics with a score of 60%. This practice sees children and adults. There are 8 measures in which they have the opportunity to meet the target. In this example, the Fletcher family practice did not see any young children, so they were not scored on the well child visits for children ages 6 years of age or the childhood immunization, which pertains to children who have immunizations by their 2nd birthday. Note a 0 in denominator and numerator on those pediatric measures. The practice met their target for the adolescent well care visits. 50.4% of their attributed recipients were in the denominator. They did not meet the target in getting those adolescents immunized. 100 adolescents met the criteria for getting immunized, but only 22 were immunized with the vaccines listed in combination 2. Immunization status, adolescent combination 2, the denominator shows 100, the numerator shows 22, the quality score is 20%, and the benchmark is 24.6%, and the target was not met. For adults, the practice did not have any recipients with antidepressant medication. This quality measure does not apply to the practice, and they will not be scored on this measure. The practice was unsuccessful in getting enough recipients tested for A1C and did not meet the target. Practice was successful in ensuring that recipients followed up after their ED visit related to alcohol and other drug use within the same time frame. 60% of their patients did, which surpasses the 12.4 standard benchmark on the follow-up after ED adult quality measure. The practice also met their target with chlamydia screening. You will be evaluated only on measures where recipients are attributed to your practice. There are more details about child quality measures. W, 34CH, well child visits in the 3rd, 4th, 5th, and 6th years of life are described as the percentage of children ages 3 to 6 who had 1 or more well child visits with a primary care practitioner, PCP, during the measurement year. The benchmark is 66.7%, and I will explain more about benchmarks later. Adolescent well care visits are described as percentage of adolescents ages 12 to 21 who had at least 1 comprehensive well care visit with a primary care practitioner, PCP, or an obstetric gynecologic OBGYN practitioner during the measurement year. The benchmark is 45%. The benchmarks are from CMS and are determined based on data captured from all states that reported on the measure. This is a statewide benchmark, which means we're holding everyone to that same standard, and we do follow a standard protocol. This rate shows the performance rate among all states. This says that 66.7%, and this is looking at well child visits. This says that 66% of children in the United States between 3 and 6 years old had 1 or more PCP visits during the measurement year. Childhood immunization status is described as the percentage of children ages 2 who had the following vaccines by their 2nd birthday. This measure calculates a rate for each vaccine and 9 separate combination rates. The benchmark is 74%. Immunizations for adolescents is described as the percentage of adolescents ages 8 to 13 who had the following vaccine series by their 13th birthday. This measure calculates a rate for each vaccine and 2 combination rates. The benchmark is 24.6%. Below is the table. This slide shows the table that lists the vaccines and the combinations of the childhood vaccines. Combination 3 is the rate of children who had these vaccines by their 2nd birthday. We do take into consideration guidelines about the administering schedule of doses. There are 7 vaccines that make up combination 3. They are DTaP, IPV, MR, HIV, Hep B, ZV, and PCV. The adolescent immunizations calculate meningococcal, Tdap, and HPV. Next are the adult measures. AMMAD, antidepressant medication management. The continuation phase is described as the percentage of beneficiaries age 18 and older who were treated with antidepressant medication, had a diagnosis of major depression, and who remained on an antidepressant medication treatment for at least 180 days or 6 months. The benchmark is 37.1%. HA1C-AD, comprehensive diabetes care. Hemoglobin A1C testing is described as the percentage of beneficiaries ages 18 to 75 with diabetes type 1 and type 2 who had a hemoglobin A1C, HbA1c test. The benchmark is 83.3%. The FA measure is described as the percentage of emergency department visits for beneficiaries age 18 and older with a principal diagnosis of alcohol or other drug abuse or dependence who had a follow-up visit for alcohol or other drug abuse or dependence. Additionally, it is the percentage of ED visits for AOD abuse or dependence for which the beneficiary received follow-up within 30 days of the ED visit, 31 days total. The ED visit day counts as day 1, then to follow up. The benchmark is 0.4%. Chlamydia screening in women is described as the percentage of women ages 21 to 24 who were identified as sexually active and who had at least 1 test for chlamydia during the measurement year. The benchmark is 54.3%. Those are the 8 provider quality measures. 4 child measures pertaining to PCP visits and immunizations, and 4 adult measures about antidepressant medication management, A1C testing, follow-up for alcohol and other drug abuse or dependence after ED visits for alcohol and other drug abuse or dependence, and chlamydia. Links to the quality measures and other supporting data will be shown towards the end of this presentation. Now, Barry Campbell, Director of Analytics, will present information on payment methodology and quality measures. There will be a 30-second delay while we transition speakers.
Our next section, Paying for Quality, will focus on the determination of and the distribution of our bonus payments for quality metrics. It will also provide a step-by-step scenario using a hypothetical practice. As a reminder, our new payment structure beginning October 1 will include an enhanced fee-for-service rate structure for certain procedure codes, but bonuses will also be awarded on a quarterly basis for 3 metrics: quality measure performance, cost effectiveness, and patient-centered medical home activities. As previously mentioned in our attribution slides, attribution also has an impact on our bonus methodology, all 3 metrics, including quality, cost, and centered medical home activities. As seen in the schedule below, payments in year 1 are based on attribution. The first calculated quality measure bonus will not be made until the summer of 2020. This will ensure the agency has adequate time to calculate the measures for calendar year 2020 with sufficient time for claims runout. During this time, however, the agency will issue quarterly scorecards that will allow practices to monitor their progress towards benchmarks. There's a bonus pool that will be available the first year of the program. The pool will be $15 million to be awarded annually. This will be distributed evenly over 4 quarters. Below, you will see how the pool will be allocated. 50% of this pool will be allocated for quality metrics, which will be discussed in detail today, 45% for cost effectiveness, which will be discussed on a future webinar later this week, and 5% for patient-centered medical home recognition. I would also note the first quarterly payment will be made on the first check write in November of 2019. Subsequent payments will be made on a quarterly basis beginning in January 2020. Participating groups will be eligible for a bonus payment if the group meets the following requirements below. As mentioned earlier, the first 7 quarters of the program, all practice groups will automatically receive a quality bonus payment depending upon attribution of members. Beginning in July of 2021 is when the awards for quality will be distributed based on calculated measures. Finally, benchmarks will be posted soon at www.medicaid.alabama.gov. Now, we're going to walk through a step-by-step example using a hypothetical provider group, Gallagher Family Practice. There are 2 assumptions that will underlie every step in this process in this scenario. The agency is estimating approximately 500,000 attributed members statewide. This number will not be known for certain until the end of September and will be officially distributed during the month of October, and attribution will be formally awarded in November. Also, this scenario assumes a quarterly bonus payment for quality of $1.875 million. We're going to walk through this flowchart process, which consists of 3 primary processes. The first process is member attribution. The second process is quality scoring, and the third process is bonus payment determination and distribution. We're going to go through each process at a time. We'll stop at the end of each process with the flowchart and go through a more detailed numerical step-by-step scenario. So for our first process step, member attribution, we use Gallagher Family Practice as our example with an attributed number of members of 6,300. The next, which is in step A. Moving to your right at the top of the chart, we move to step B, where we calculate the distribution rate of attributed members. This is calculated by taking the members attributed in the quarter for Gallagher Family Practice. This is 6,300. We divide that by the total statewide ACHN attributed members of 500,000. This gives us a distribution rate of attributed members of 1.26%. The next table shows a hypothetical scenario for Gallagher practice and how this practice compares to other practices across the state. This, of course, is a hypothetical scenario with only 10 provider groups used for illustration purposes. The agency anticipates more than 600 practices will be participating once the program begins in October. But in this particular example, you can see our practice, Gallagher, in column A with 6,300 members and the distribution of members as noted in the flow chart. You can see how the rest of the practices are calculated based on their member attribution as a percentage of the total statewide attributed members. Now I'm going to go back to the flow chart, the second step in our process. This step will go into a little more detail, the quality scoring methodology as it pertains to bonus calculations. Starting at the top right part of this flow chart in step C, we'll begin with the quality score calculation. You saw an example earlier of a practice that had a quality score of 60%. In this particular example, we are assuming Gallagher Family Practice is qualified for all 8 quality metrics. Also, in our example, we are assuming Gallagher Family Practice met 5 of these 8 metrics. Therefore, they have a score of 62.5%. That is their quality score. In order to qualify for quarterly bonus, the practice must meet at least 50% of applicable metrics. In this case, Gallagher Family Practice met this metric. Therefore, we move on to step D, going right to left. In this case, Gallagher Family Practice qualifies for the quality bonus. Now we move on to step E and F. And this is where we eliminate attributed members in groups that have not met the quality minimum for this quarter. In this case, we combine steps E and F to calculate a distribution rate of attributed members. This rate is calculated taking the group's attributed members, again, 6,300 in the case of Gallagher, divided by the attributed members in groups meeting the quality metric minimum. As you'll see in our next numerical scenario, this number is in this example is 359,000 attributed members. What this equates to is a 1.75% distribution rate of attributed members. Again, I'll stop at this process step and move back to our numerical illustration. Focusing on the outline quality scoring step of this, you'll see our practice, Gallagher, the 1.75% member distribution. You'll see how the number is calculated by observing the other practices in the state. In the case of PCP group number 3, they did not meet the quality score minimum. Therefore, their attributed members is taken out of this calculation. These examples show you how, in our example, this number is up 359,000 roughly. Process flow will end with the third part of our process, which is the actual calculation of the bonus payment and distribution of the bonus payment. The bottom left step in our illustration, step G, we calculate an initial bonus distribution rate. This bonus distribution rate equals the quality score of the particular practice. Again, in the case of Gallagher Family Practice, we apply the quality score of 62.5%, multiply that times the distribution rate for members and groups meeting the quality metric minimum as noted in the step above. This number is 1.1%. The important part of this next process is called normalization. And effectively, normalization is what we're doing to ensure that 100% of our allocated bonus pool is spent. And that is done by calculating a normalized bonus distribution rate, which is the bonus distribution rate for this practice is 1.1% in the case of Gallagher. This is divided by the sum of the pre-normalized bonus distribution rates for qualifying groups. What this means is this is adding up the bonus rates for each practice that meets the quality score minimums. As you'll see in our chart on the next slide, in this case we're using 74.1%. Calculation brings us to a 1.48% normalized bonus distribution rate in step H. The final step in our determination process is right below in the green circle. This is step I. This is the bonus distribution amount. This is taking the normalized bonus distribution rate above, 1.48%, applying it to the quarterly pool amount, in this case, $1.875 million. That gives us a bonus payment of almost $8,000 for this practice. Again, we'll use a numerical illustration to show how we got to that number. This is, again, the third step of our process, payment determination. We use our Gallagher practice to show, again, the pre-normalized bonus distribution rate of 1.1%. We normalize it by taking that and dividing it by the individual rates for every qualifying practice. In this case, if you look at step G, you'll see that number adds up to the 74% that you saw in the previous slide. By normalizing these, this gets each qualifying practice to the 100%. We then apply that percentage to the quarterly bonus payment to get to the normalized distribution amount per practice. This last slide provides links to publicly available resources that give information on the specifications and other resources for our quality measures. Before we open the webinar for questions, I would turn it over to Jerry Jackson, who will provide an update on our BMI reporting.
Hello, this is Jerry Jackson. I wanted to give a quick update on where we are with BMI reporting. From our last presentation or the previous presentations, we've had feedback from several of you, and that feedback has been taken into consideration, and as a result, we're making a slight modification to ease the requirement. So the BMI coding will be required on each claim. However, the same BMI can be reused until the next well child check. And remember, this is concerning well child checks and the child, where a BMI is typically determined or sooner if the physician feels there is a clinical need to redetermine that BMI. We'll also be monitoring the issue over the next year, and since we're so close to the ACHN go live, a major modification will not be reasonably feasible at this time. Additionally, if you have a recipient that it would be difficult for you to obtain a BMI, such as if they were wheelchair bound, you may send the claim in for an override to the managed care division.
We will now open up the forum for questions. My apologies. Before we open this up for questions, Dr. Moon would like to have a few words.
Great. This is Dr. Moon. I just wanted to provide a few comments. First of all, thanks to everyone who is participating in these webinars. Greatly appreciated. We've had very strong attendance on every single webinar we've done to date. Just as a reminder, the webinars are recorded and are posted on our website. The previous 3 that have been done are already posted, and you can watch a recording of those now. This is the middle webinar. There are 3 more to be done very near future. This Thursday, there will be a webinar focused on calculating the cost-effectiveness bonus. The following week will be a webinar related to obstetrical providers, DHCPs, and will be focused on their aspects of this program. And the last webinar will be an open forum to deal with residual questions that we've either already received or received that day. I do want to remind everyone that this ACHN program oversees literally hundreds of thousands of recipients who utilize Medicaid coverage. Also a reminder, our go live is October the 1st, which is literally 14 days away. So we're imminent in terms of the program going live. ACHNs, starting October 1, will be answering calls. Full care coordination actually starts November the 1st. And finally, existing health homes and the maternity contractors are expected to continue their full activities through September 30th. We've made a special outreach this morning to one of those groups in particular. They are expected to continue their full activities through September 30th. So with that, I will turn it over to the next speaker.
We will now take questions. First, what is the minimum number of eligible recipients a practice must have in order to be graded? The answer is 1. The agency has made a programmatic decision to allow participation in the bonus pool to all practices regardless of the practice size or the number of attributed members. What we would suggest is that the best way to address the validity of the sample is to increase the sample by adding Medicaid recipients to your pool, seeing those recipients. What happens in years moving forward if the specifications change or CMS replaces specifications? The answer is it is important for Medicaid to use validated metrics. In this particular scenario, if the measures stewards do change, we will change accordingly. We will make appropriate adjustments to the measure selection and communicate adequately to all providers. And we will provide sufficient notice as well. If I have a pediatric practice, not all of my patients will be eligible for the adult measures. Is there a method to create this disparity? Yes, in short, the practice, again, will qualify based on the metrics, the attributed members, and the denominator for any given metric. So in this case, if the pediatric group had recipients that were only in the denominator for the 4 pediatric measures, that particular practice would be graded based on those 4. So if they scored 50% or higher, in this case 2 of 4, they would qualify for a bonus payment. How will Medicaid attribute new recipients? That is, those who do not have a 2 years window of claims history. Again, as we've discussed today and in previous webinars, Medicaid attributes recipients based on claims history within the last 2 years, based on eligibility within the last 2 years. Finally, we have additional questions in addition to this. My understanding is that national measures are annual measures. If we are going to be receiving quarterly bonuses, are you going to be recalculating them quarterly? That's a good question. The answer is no. Quality measures are based on calendar years worth of data. However, on a quarterly basis, the number of attributed members in both the denominators and numerators could change in a particular case. But in short, quality measures are calculated on a calendar year basis. Next question, for combination 3 and combination 2 measures for vaccinations, which vaccination schedule does this measure follow?
I'll take that one, Barry. The measure specification do outline how many vaccines and when they should be administered by. For example, there are 4 DTaP vaccines that are required to be a part of the childhood immunization. The technical specifications located at the Medicaid.gov website will give you clear specifications on that information, and we did share links in the slides today.
Okay. The immunizations tracked by CPT codes. Yes, it's a combination of CPT codes and ADPH registry data.
Also, that information will be in the technical specifications of the quality measures.
Next question. Does BMI have to be reported on every claim or just the well child check? The BMI must be reported on every claim. However, you can use the same BMI until the next well child visit.
At this point, that's all the questions we have. We thank you for your participation in today's webinar. And as a reminder, the next webinar is scheduled for this Thursday at 12 o'clock Central Time, where we will go over in detail the cost effectiveness bonus calculation and distribution methodology. Thank you again.